I'd like to introduce Dr. Rukundo from Mbarara in Uganda. He was able to join us. So we're very, very happy that he's able to join us today. And I'll just give you a quick background, Dr. Rukundo. So he is a child and adolescent psychiatrist and a senior lecturer. And he's actually head of the Department of Psychiatry at Mbarara University of Science and Technology, also known as MUST. He's been a faculty member there since 2001. His research focus has been on depression, suicide, child and adolescent mental health, and mental disorders secondary to general medical conditions. He's successfully supervised several research projects of PhD, master's, and undergraduate students at MUST, as well as in other institutions. Dr. Rukundo has been a clinician for over 20 years with experience in different settings. I've had the opportunity to work with him in Mbarara a few years ago, and we collaborated on a research project looking at teenage pregnancy and barriers to care for teenage girls that were pregnant. And this was in the context of a micro-research workshop that you will hear more about tomorrow from our keynote speaker, Dr. Noni McDonald, who will be speaking about this and some of the experiences. Finally, I should mention that MUST, so the Mbarara University of Science and Technology, is a strong partner of ours here at the U of A in our global health program. For several years, we've had learners as well as faculty exchanges, both virtually and in person, and we've been able to share our knowledge from both sites, and we've had some neat research as well as educational opportunities for both learners and faculty members and so on. So at this point, I'd like to invite Dr. Rukundo to present to us.
I wouldn't be able to share if I use a phone. So I was saying that for today we are going to talk about child psychiatry, looking at the burden and the opportunities in low-income settings like Uganda, where I have worked for many years. And I'll just try to share the slides again so that you can see what I'm talking about. So I'll not go through the introduction again since Dominic has already done it.
And Dr. Rukundo, sorry, are you able to maximize your slides? Yeah, perfect.
Yes, so as many of you may know, half of all the disorders we see in adults actually start by the age of 14. And by 24 years, about 75% of the disorders we see in adults have already emerged. So the burden of mental disorders or mental illness actually starts in childhood, adolescence, and also in early adulthood. And you know that suicide is one of the most common causes of death among adolescents and young adults. And unfortunately, although we have many disorders starting in childhood and the adolescence, very few get services early. The median number of years from the onset of psychiatric disturbance receiving treatment is 9 years, which is a very, very long time. And in low and middle income countries, we have a short supply of mental health workers that have specialized in children and adolescents. So what are some of the risk factors for mental disorders in children and adolescents? One of them is poverty. And poverty is, I think, one of the main characteristics for low and middle income countries. It is what the World Bank bases on mainly to classify countries in different clusters. So, and poverty comes with worry about the future, worry about survival, there's insecurity, there's malnutrition, and many other challenges that come with poverty. And the other challenge is inconsistent caregiving. Where the resources are limited, the children and adolescents will not be sure of what next. So today they may have good care, tomorrow they may have challenging care. So that inconsistency in caregiving is a risk factor for child psychopathology. And then we also have a high burden of mental disorders among the adults who are the parents for these children. So that is a challenge. And then we have high rates of mortality. And we have had many children growing up as orphans, in some cases as the only surviving individuals in a family. The previous speaker talked about the wars that we have had. She has talked about HIV, and all those brought up many orphans in this country, like in Uganda. But also, this is not specific for Uganda. It happens in many other developing countries. Then there's family breakups, early pregnancy, like Dominic talked about. And then we have challenges with birth. Many of the mothers deliver in their homes or in the rural settings, and they are likely to get neonatal complications. And these are risk factors for child psychopathology. I just got this picture for you to see some of the aspects of poverty. This is mainly in Africa, but also it happens in other countries as well, which have low resources. So poverty is correlated with less education, inadequate health care, poor nutrition, but also greater likelihood of exposure to violence. I think most of the violence is actually happening in the low and middle income countries. And this one increases the risk for mental disorders, especially in children and adolescents who have to depend on the adults. And sometimes the adults have no answers to the questions these young people may raise. I just took this picture in Uganda when we had landslides, and people were helpless, seated in one place, wondering what to do next. So we have also had such natural disasters which pose a high risk for mental disorders in children and adolescents who are often left helpless. So some of these disorders in children and adolescents are actually identified in adolescence. And although adolescence is supposed to be a period in which people are healthiest, they have the strength, they have learned the speed, they have mastered some of the areas that they are interested in, and they are supposed to be having good immunity. But there is also a challenge. There is an increase in morbidity and mortality in adolescents going forward. And some of the causes of mortality in adolescents, as you may know, we have accidents, we have homicide and suicide. So it's like a paradox. A time when people are supposed to be healthy, that's when their mortality rate goes up. So, but in adolescents also there is increased responsibility, there are academic demands, there are negative life events. The adolescents want to spend a lot of time alone, but also there is a lot of friction between what is expected and also what life brings before them. But also these people they have the ability to abstract. They are likely to think about different things and put ideas together. And this is the time they also learn to form intimate relationships. And all these come with the disappointments. So in low and middle income countries, children and adolescents find themselves living in dangerous environments, especially because of poverty. But also, most of the schools which are considered to be good, they are boarding schools. And most parents, because they have to go to look for income, they have to go and look for jobs, or they have many children they cannot take care of at school and drop school every morning. I mean, they cannot take care of them at home and drop them at school every morning and pick them in the evening. They choose to put them in boarding schools when they are still young. And this one has come with so many challenges as the children grow up. And because of the poverty, because of the economic hardships, parents also undergoing a lot of stress. And in many low and middle income countries, like African countries, people still believe in harsh physical punishments, the corporal punishments. And of course, these come with the challenges on mental health. We have limited classrooms, so the students are likely to sit in crowded classrooms, and of course learning becomes a challenge, and therefore they get inconsistent quality of education. In the developed world, the classes may be having a similar curriculum, and the schools have well-trained teachers, but in low and middle income countries, you find that the best schools and the best teachers are around cities or towns, and in the rural areas, the teachers are of low quality, and also the schools are of low quality. And therefore, the education becomes also of low quality. So most of the people with mental disorders, most of these young people with mental disorders do not receive care because we don't have a full range of services they need in low and middle income countries. So they only take those maybe who they think are very disturbed, and usually those who are psychotic. But those who are depressed, those who are anxious are not likely to be taken for care. And the services for children and adolescents, ideally they are supposed to focus on the individual, on the family, on the environment, and of course also the education. But most of the services in low and middle income countries will focus on the individual and leave out the other maybe predisposing factors, the precipitating factors, and the perpetuating factors, which are usually in the family and the environment generally. The communities do not know how to manage mental disorders. So when a young person gets mentally ill, they will do whatever they can. I just took this picture of a young man, an adolescent who was brought to my office because he had developed manic symptoms, and they had tied him and dressed him, and they brought him to a small clinical room where I was sitting, seeing patients. So this increases the fear in the adolescent, but also it causes hopelessness when they see themselves being handled like criminals or like dangerous people. So in most low and middle income countries, child and adolescent mental health is low on the priority list because most of the concern is put on mortality rather than morbidity. They think of killer diseases, but then they don't look at life lost due to disability. And there is, of course, inability to work because the parents have to go and take care of the children, and therefore they will continue that cycle of poverty. But also we have been noticing that in our settings, there are family disruptions. Although initially families would be together and bringing the children together, now we are taking on like individualistic bringing of children. For example, a nuclear family has to be responsible to bring up their own child. So if the family does not have the resources, it is no longer possible for the extended family to support in many settings. And then children in these settings, by the time they grow up, they have gone through a lot of insults because of the environments that I have already described. And because of the poverty again, there is a lot of domestic violence due to the poverty, but also due to the traumas that people have gone through. There's a lot of domestic violence. Again, just emphasizing what I had said earlier, most of the people with mental disorders may not come to hospital. This picture, I took it when we visited a certain village, and we found that a young woman had become psychotic. They had not brought her to the hospital. They just tied her on her bed and left her there alone. So they would just bring her food there and she would stay there. So, but then we were tipped by a neighbor who told us about the condition, and we went there to support the family. So there is reluctance to seek help because people think that mental illness is not a medical condition. Maybe it is a traditional, or it is cultural, or it is demonic, and therefore they think care should be sought from traditional healers or from other sources. And of course, there is negative attitude towards people with mental illness, including the health workers. Health workers also stigmatize patients with mental illness, including children and adolescents. But also, the health workers have a bias to physical illness, so they are not likely to assess for mental disorders conditions. But also in our experience, we have seen that people believe that children do not suffer from mental illness. They associate mental illness with stress, maybe with economic hardships or marital problems. So they think that children who are being provided for and who are protected in their homes, they should not suffer from mental illness. And I think that one now is related to the reluctance to seek help. And we have so many religious groups which often interfere with the treatment for mental disorders because they believe that medical workers cannot treat mental disorders. So we find many patients being taken to churches and mosques and shrines for traditional rituals or for prayers. So children who tend to be at risk of mental illness, in addition to what I have mentioned, are those with current conditions like HIV, which my colleague has already talked about, streets of all the towns and the cities in Uganda and the other developing countries, and those who perform, who are in school, and then those who are in conflict areas like where there have been many children with psychiatric conditions because of the trauma that has been going on in that area. And the family is preparing to have a child, they develop a mental illness. The parents are shocked, or they are surprised, they're in denial, and they will not accept that the child has a mental illness. And also, they will fear to mention because of the stigma, they fear to be blamed as the sources of the mental illness, and of course, they carry shame because of the mental illness. So mental illness is not just for the child, but it's also for the family. So they blame the entire family or the shame. So from the onset of the illness to acceptance that the child has a mental illness is a very long journey, and is often difficult. And that's why the parents will take long to bring their children to hospital for care. And of course, children will fail to develop their social, functional, and academic skills, which they need to succeed in life. And of course, because of these behaviors which come due to the mental illness, other people may fail to cope with them, much as the individuals are also failing to cope with those symptoms. And of course, the children will not be able to enjoy their childhood because of their mental illness. So because families are not able to talk about the mental disorders in their children, they usually live in silos, and therefore they are not able to seek the appropriate care. And they may fail to get resources to cope with the challenges associated with their children's mental illness. So what are the opportunities for child and adolescent psychiatry in low and middle income countries? We have noted over the years that professionals working with the children and their families in low and middle income countries, they work across many systems and boundaries. We shall talk about boundaries in mental health and especially child psychiatry. But in these settings, the workers find themselves working in different areas and therefore getting more experience in handling different issues. Because where you would want maybe to refer to a social worker, you may not be able to get one, so you have to do the work of a social worker as well. So they often become creative and they are resilient in whatever they are doing, and they show great persistence. The other opportunity is that there are so many unstudied areas, so there's a lot of research that can be done because much of the areas have not been studied. And for those who want to be trained in child and adolescent mental health, there is a high burden of the mental disorders, so they can come to such settings for clinical training. But also there's the opportunities for collaborative research because we are also interested in collaborative work, in evidence, that whatever we do here is evidence-based, and also doing clinical work together. The other opportunity is that there are not so many interventions that have been put into practice here in low and middle income countries, and therefore we can be able to experiment many therapies or many treatments in these settings to see what works. So there's still that opportunity. I'm sorry I may have taken a long time, but I will end there and leave room for questions.